just kind of focus on her. I'm going to point out some things, but I'm going to start with the check off. Basically, you can articulate all this before you get going in your exam because it's going to apply to every body section. But inspection palpation, basically skeleton extremities, you're going to compare sides, contour symmetry, any gross deformity, alignment, skin and subcutaneous tissues over the muscles, looking for color, discoloration, skin folds, abnormalities, swelling, masses. And then muscles, you're going to compare again side to side for symmetry, any fasciculation, spasms. Palpate all bones, joints, prominences for muscle tone, heat, tenderness, swelling, any crepitus. And then each major joint for active and passive range of motion. So we talked about that in the lecture. Remember, active range of motion is the patient doing it on their own. Passive is going to be the examiner pushing it. And I use the shoulder as a good example for that. If you have normal active range of motion, then there's really no reason to do passive because you know it's normal. If in the instance the patient can only raise their arm this far actively, and then you can get it here, that would imply that the person probably has a rotator cuff tear because they have weakness, okay? If they can only reach it this far and you can only push it this far, then that would suggest that they have what's called an adhesive capsulitis or frozen shoulder, which you'll get if you just hold it still and guard it for weeks and weeks. Doesn't mean that there's not other pathology there. They could still have a rotator cuff. In fact, that'll happen a lot of times is they'll just not be able to move it, so they hold it still. But that's a good indication. When you have a deficit in active range of motion, then you should do passive range of motion, okay? And then finally, joint groups for strength. So if you think about what you're doing as you run them through range of motion, you want to also put resistance to that range of motion to test the muscles that are firing that create that range of motion. In other words, elbow flexion and extension is biceps, triceps. So if you put resistance against flexion and extension, you're testing that muscle strength. So as you go through and do the range of motion, you're going to test resistance against that exact thing, so you'll know what to do, okay? So we're going to start. I'm going to follow the outline of the checkoff sheet with the hands. So you're going to, again, you're palpating, just like you're going to do everywhere else, joints, surfaces, and then you'll mirror with the patient. So what I'm going to have her do is bring your fingers down like this. So that's flexion at the MCP joints. Make a fist that brings them all the way in. Open them up and then spread them out and put them together. Bring them up like that. Okay, good. And then bring your thumb across and to the side. Good. Okay, now hold them out there. So push your fingers down and push them up. Spread them apart, hold them apart, and squeeze them together. Make circles. Don't let me pull through. So you notice there's a little redundancy with the neuro exam there too, but that's checking muscle strength of the hand, okay? Wrists, so extension, flexion, ulnar deviation, radial deviation. Same thing, put them out there, raise your wrist up to the ceiling, push them down, push them out to the side and in. Again, I'm just providing resistance to those motions to test for muscle strength. We'll get to the elbow, same thing goes, you can do these at the same time. So elbow flexion, extension, and then hold your hand out like this, and you have pronation and supination. Ready to remember that? If Superman falls out of the sky, you gotta catch him like this, that's supination. Pronation, if you're a pro basketball player, you gotta dribble the ball like this. So pronation, supination. Okay. Pull towards you, so that's biceps, triceps, and then turn your hand that way, other way. Good, good. And so I'm just providing resistance against those, and you're going to compare side to side, and you can actually do it at the same time to get a better feel. So pull towards you, push away. Good, turn your hands out, turn them in. Good. So if you do it at the same time, you really get a better comparison of strength side to side. Shoulder. So forward flexion gets you here, extension, abduction, adduction, okay, and then internal rotation, external rotation. Another way to do it is have them put their hands behind the back so you know they go at least to 90 degrees of internal, and this way is external rotation. So that's both really the same thing when you're checking internal and external rotation. Rotator cuff strength. So hands out in front of you, you're gonna push out. So that's testing the external rotators, the teres minor and infraspinatus muscle. Control that. Push in. That's subscapularis. Pull towards your belly. Same thing.
Oh.
Like this way.
Oh, man.
Yeah. So push in. So that's subscapularis. Thumbs to the floor and arms out like that. Push up to the ceiling. And that's supraspinatus. That's the most common rotator cuff muscle of the group that's going to be torn with injuries, the supraspinatus. You can also check shrug. Good. Okay, cervical spine. Forward flexion, so look down. Look up to the ceiling, that's extension. Look straight ahead. Now lean your ear over to your shoulder and to the other way. That's lateral flexion. Look straight ahead. Turn your head towards me now. Rotation and then away. So that's rotation. I'm gonna go ahead and, if you want to come up closer and look at this, I'm gonna demonstrate just basically on the elbow here, the goniometer. So the thing with the goniometer is you want to have this central pivot portion over the area in the joint that is going to be the pivot. In other words, it's not going to move that motion. And so with flexion, we're starting here, and you can see the 0 is here. And as I move, you're measuring the degrees of motion right up on it. And you can see that that goes to about 135 degrees right there. And then we fully extend, that gets us to 180 degrees, okay? So that's the key thing. And so the key thing with the goniometer is understanding where the point of rotation is, and that's different from place to place. For example, in the cervical spine, when we measure rotation, if you just look straight ahead, now rotate towards me. So the area that doesn't move is right basically here. So look straight ahead. So I'm getting this plane right there. Now look towards me, and then I get it aligned up with that plane this way, and that tells me where the rotation is. And that's about 70 degrees, and that's normal, okay? So you would follow that both ways with the goniometer. Okay, go ahead and stand up now. So thoracolumbar spine will measure together. Take a step forward, and now turn around towards the wall that way. There you go. So back up a step so you don't hit your head on that. Okay, so lumbar, thoracolumbar, we measure together. So forward flexion, lean over, touch your toes. So the pivot is right basically at the pelvis here. And so that's your line that you're starting with, and you're comparing the side here with flexion. So it should be 70 to 90 degrees of flexion, stand up. And the same thing, the point of rotation is here, lean backwards, so that's extension, good. And then we move around here for lateral flexion, basically right here, and then you're gonna lean towards me, and you'll measure that from that point. So your goniometer would line up here, and then you would follow it over. And same thing that way. That's about 30 degrees. Now I have a seat back up here. So truncal rotation, I have them sit down because if they're standing up and they do this, a lot of times they'll move their pelvis, and you're not really measuring rotation. So this stabilizes the pelvis. Rotate this way, that's about 45 degrees, and this way, again, should be about 45 degrees. Okay, go ahead and lay back on the table. We're gonna go to the hips. So forward flexion of the hip, it's at about 90 degrees. You can see the same plane that we're looking at. And then abduction is out this way. Adduction is this way. And then roll over on your belly. And extension is measured this way, so bringing it up this way. So rotate, so you notice that she's bringing her pelvis up, so you want to keep that there and then bring it straight up, measure it that way. Okay, now, muscle strength. Push up against me, so that's resistance. Now roll back over on your back. And then do a straight leg raise, okay? Now you can measure both the adductors and abductors at the same time. Push your feet apart. Good, and I pull them together. So that's measuring the strength both at the same time with those. So hip, internal and external rotation. Think about where the rotation is actually taking place is in the hip joint. So when I bring the foot out, that's actually internal rotation and external rotation, okay? Now, when you're doing this, this is another way to show external rotation. But when you have a patient that presents and says, I have hip pain, it could be a number of things. If it's hip pain is here, it's probably the joint. If it's out here, it's probably a bursitis. If it's back here, it could be SI joint, sciatica, or sort of a lumbar radicular type pain. This is called the Faber test, so flexion, external rotation, and abduction. Set them out of order. Flexion, abduction, external rotation gives you Faber. So I'm putting my hand right on the anterior iliac spine and press down on the knee. And wherever that recreates the pain, if it's in the front here, that would tell you it's the joint, the capsule, or arthritis or something. Or if it hurts in the back, it could be SI joint pain. Another way to test that is to bring the knee up, and if you're stretching that and she has a sciatica, that's going to make a little bit increase in pain there as well. Palpation on the lateral aspect where the greater trochanteric bursa is, tender right there is going to tell you that's like a bursitis. So when somebody says, I have hip pain, you have to get very specific. Show me where that pain is. And there's a rationale behind doing that process, okay? So knee, range of motion is flexion and extension. Basically flexion, extension. I'm going to put my hand right here, and I want you to push your knee up. So that fires the quads, pull down towards the ground. That's the hamstrings. So test muscle strength of motion for the knee joint. The ankles. So from a neutral position, I want you to pull your toes up towards your head, and she should be able to dorsiflex 20 degrees. And then push, while I'm doing it, I'm going to test strength at the same time. So pull up, good, push down, and then plantar flexion, inversion, and eversion, okay, and then push out, push in. So I'm, again, testing muscle strength on those as they go. Pull your toes up towards your head. So the great toe specifically, that's the extensor hallucis longus tendon. If she has weakness in that great toe, that would suggest probably L4-5 disc herniation. Okay, so again, you can test them both at the same time and compare, and they should be able to pull that toe up against resistance very easily. Okay, again, same thing with the foot. You're going to palpate all the joints and bones in the foot itself for any tenderness. Okay, now we're going to go to the special tests that go kind of body region by body region. I'm going to start with the shoulder. This is the most complex set of exam techniques. What I've showed you with the checkoff is basically what you're going to do for a head-to-toe normal screen on musculoskeletal on somebody. If they have specific complaints of the body region, then you're going to do more testing, obviously. So we've already tested for rotator cuff when we tested the strength, so that's what you're testing for, is a rotator cuff tear. Another thing that will occur more commonly actually is what we call an impingement. So the rotator cuff attaches to the humerus, just like a cuff all the way around it, and over the top of it is the acromion. So there's very little space between the humeral head and the acromion to accommodate that muscle in there. It's a very thin muscle. If it gets irritated, it will thicken, or traumatized, it can thicken. And what happens is it starts bumping up against his acromion. So the two tests that you do for this is, it's called an impingement. So this is the Neer's test. So the way to remember it is you're putting your arm up near the head. So, and then I'm rotating internally. So the rotation is taking place at the shoulder. So I'm holding a wrist, but then I'm going to internally rotate the whole shoulder like that. And that will reproduce her pain. Okay, and that's an impingement syndrome. The other one is Hawkins test. And remember that because like the hawk wings hawk. So I'll bring it out 90 degrees, and then internally rotate. And so it's basically testing the same thing with the glenohumeral joint in two different positions is all. So that's shoulder impingement. Moving on, the top right up here is where the clavicle attaches to the acromion. There's a ligament there, it's called the AC joint. And we're gonna just palpate there for tenderness. And if they've had an injury to it or over time develop pain, they can get with either an AC joint sprain or separation or AC arthrosis or arthritis. And so we're gonna palpate for tenderness there. One of the things that causes this is people that bench press a whole lot over a long period of time. When you bench press, the force of that is transmitted to this AC joint and it absorbs a lot of the pressure from that weight. And so another way to test it is to do cross-body abduction, and that compresses that AC joint. More specifically, make a fist, turn it this way. So this looks almost like the Hawkins test, but you're doing something different. I'm supporting under the elbow, push up that fist against my hand, and that'll recreate that pain right there for me. That's also AC compression test. Okay, so rotator cuff tear, impingement, AC joint conditions, and AC, if they have an injury, the clavicle, actually the ligament can tear and you get what's called an AC separation. So grade 1 would be tenderness with no elevation of the clavicle. The clavicle raises up a centimeter, that's a grade 2. And if it raises up more than a centimeter, that's a grade 3 because the ligament here is torn in the AC joint, but also the corticoclavicular ligament is torn. And that would be a grade 3 sprain. You would get an x-ray to see that, but the clavicle would basically raise up higher than the acromion. Grade 4 means it's up through the muscle. Grade 5, it's tinning the skin or actually open. 4 and 5 would require surgery. 3, if you're a pro athlete or college athlete, they might operate on and fix that. With the average Joe on the street, they would just leave that alone because it doesn't affect the shoulder girdle function in any way, really, just to have that separation here. So, now, biceps tendonitis. So the biceps tendon inserts in the radius down here, and it comes up through the bicipital groove over the humeral head and attaches in the glenoid to the glenoid. And so overuse of that, people do too much curling or repetitive motions can develop a biceps tendonitis. So they might have pain anteriorly, and you can feel your biceps tendon right there. So a test that we do is called the SPEEDS test. Open your palm. Again, I'm supporting under the elbow. Push your palm to the ceiling. And that's going to reproduce that pain up there proximally. If they actually rupture this biceps tendon at the proximal attachment, so the biceps tendon will ball up. If it detaches down here, you actually have to have surgery to reattach that. A proximal rupture up here, because there's 2 heads to the biceps, 2 attachments there, doesn't necessarily have to have anything done. The other test is called a Jorgensen's test. So I'm going to have you rotate your hand out against force, okay? So that's putting force to fit, and that would hurt down here for what we call biceps tendonitis, okay? Another shoulder exam is to check for a labral tear. So the labrum is a lining of cartilage around the glenoid. The glenoid is very shallow, shoulder is very unstable, so that labrum actually embeds with the capsule and helps give stability to the joint itself. So I'm going to put my hand on the elbow, you lean into me, and then I kind of do a little corkscrew motion like that. And if that reproduces their pain in that shoulder, that makes it suspicious for a labral tear. Okay? So, rotator cuff tear, impingement, AC joint issues, biceps tendonitis, labral tear, and then also multidirectional instability. So if the capsule is loose, somebody that's had a dislocation in the past or multiple sometimes, stabilize the joint. My finger and thumb on the humeral head, and what I'm going to do is just feel that move back and forth in there and feel that humeral head translate across the glenoid. It shouldn't go more than about 50%. You can also pull it down, feel for a sulcus right here. Again, the same thing, you should not be able to translate it more than 50% out of the socket. If it's highly mobile, you can have what's called multi-directional instability. So go ahead and lay back now. It would be what's called apprehensive sign. And where you bring it, you externally rotate and bring this down. And they're gonna feel like their shoulder's gonna pop out of socket there. And then you push on the front and that stabilizes it and makes that feeling go away, okay? Come back up and sit up. And adhesive capsulitis, we talked a little bit about that. I'm gonna cover that again. Actively, if she can only raise her arm this far and then can't get it past that, and then I take it and I can't get it past there, that tells you it's probably adhesive capsulitis, which is very common, especially in rotator cuff injuries, because they tend to guard and they'll hold it there, they'll put it in a sling and they won't move it. They won't work on range of motion and the shoulder kind of freezes up. So a frozen shoulder is also what we call adhesive capsulitis. Okay, so that's the shoulder exam. That's a lot to that. It's on tape, so you'll be able to review that. Limb length measurement. So go ahead and lay back here. In circumstances, somebody comes in with a complaint of back pain, one of the things that you want to rule out is that they do not have a limb length discrepancy. Could be congenital, acquired over time, fractures, anything of that nature, or a lead cap perthes or something like that that creates this back pain. So to measure limb length, you're going to go from the anterior superior iliac spine, the ASIS, and you're going to measure from there to the medial malleolus, the distal tip of the medial malleolus, and that gets us to about 98. Your fault.
Yeah.
And why we do this is because this is a fixed point. This pelvis from here is always going to be consistent on either side, whether that pelvis is tilted or not. So if her pelvis is tilted down, it's going to push that foot down anyway, so it's always consistent. So, and you know where that landmark is, that very tip, the highest point in the front where that pelvis is prominent. And then same thing down here. Again, so 98. So that's consistent on both sides. Now, the other thing you measure is the circumference of the limb. So if somebody's got a disc herniation or low back pain and they're just having the onset of it, you want to get a baseline that shows that their muscles are equal on both sides. So I'm going to start at the distal tip of the patella, distal pole of the patella, go down about 12 centimeters to the mid-calf area. I'm going to measure this, the circumference of that, and that's like 39, and then I would do the same thing on both sides. The key is that you measure exactly the same distance on both sides to make sure that there's no difference in the muscle mass. Then you're going to do that proximally. So from the proximal pole, I go up about 12 centimeters, and I'm going to come around. We're going to measure that. That's about 50. So we measure both sides to make sure that's even. 6, 8 months or a year down the road, if that person is still having a lot of pain, radicular pain, and getting worse, you have a good baseline measurement. And then if they're starting to lose muscle mass, that's probably an indication for surgery, at least a neurosurgery referral, if you haven't already done an MRI, which you should do. So that would be loss of muscle mass. You can also do that on the upper extremity from cervical radicular. So you go from the elbow, mid forearm, measure that, and mid brachium, same thing, you measure the same distance on both sides. Now in upper extremities, typically your dominant arm may have a little bit more muscle mass because you'll have more strength there, especially baseball pitchers, athletes like that are using their dominant hand more, but it shouldn't be more than, on the average person, no difference, less than 1 centimeter difference from one side to the other. Again, the dominant side may be a little bit larger, but you're documenting loss of muscle mass. You'll also probably see loss of reflexes, decreased sensory, and weakness in those muscle groups related to whatever nerve root level we're dealing with. Okay, so that's limb length measurement and circumference. Cat's hand diagram, basically it's in the textbook, it'll show you, but you're just documenting the distribution of numbness and pain related to carpal tunnel syndrome. So it's a hand diagram, and it'll show you use just different marks to indicate pain or numbness or whatever it may be. And then, so with carpal tunnel, especially a workman's comp scenario, you want to document it very well, so a hand diagram is good. Also, 2-point descrim that we learned in neuro. The Tunnell's test, so basically the median nerve comes right up through here, and then there's a transverse ligament, carpal ligament that's there. And what happens is that's where the entrapment occurs. You also have flexor tendons that come through there. The flexor tendons are much more bulky and dense than the nerve itself, so the nerve gets crushed. So Tunnell's is you're going to tap there, and they're going to get electrical shocks in the median nerve distribution, which is the thumb, index, and long finger of that hand, plus the radial side of the ring finger. Tunnell's can do two different ways. The book, it shows you that you go like this, but I would like to take them and put pressure on it and hold it myself to know that we're getting the right amount of pressure. And you just hold it there for 1 minute. And then you're going to ask the patient if anything has changed. They're going to tell you that that nerve distribution is getting numb. So it's a positive Phelan's test for carpal tunnel. The other thing is thumb abduction. So push up with your thumb. The motor branch of the median nerve is solely innervates that muscle function. So if they're having weakness there, you'll also notice the thenar muscle is atrophying, maybe compared side to side. So you're going to feel that thenar muscle and test for that thumb abductor. So all of those are tests for carpal tunnel. Straight leg raise is related to low back pain with radicular symptoms. A true straight leg raise, go ahead and sit forward here. You can do this sitting or laying down. We'll show you both because you get the same result. So when there's a nerve root irritation or entrapment, by pulling this up, it's going to cause the pain to radiate down the leg past the knee. So if you do this and they say, oh, it hurts up here in my low back, that's not a positive straight leg raise. Positive straight leg raise is when this comes all the way down past the leg, that radiating pain. They'll also have some decreased sensory in there. And that's an indication of nerve root impingement from a disc herniation or foraminal stenosis. If you do it on this side, so the contralateral leg, and it actually gets worse over here too, that's more diagnostic clinically of a disc herniation, nerve root impingement, okay? So the other, so go ahead and lay back. So if you notice, we got her to a 90-degree angle. Same thing goes here. If that, even at 30 degrees, if that causes that pain to go all the way down the leg, then you're going to say she has a positive straight leg raise at 30 degrees, 60 degrees, 90 degrees, whatever it may be. Again, if it just radiates down in there or they feel some hamstring tightness, that's not a positive straight leg raise. It has to put, the radicular pain goes past it down to the foot. Yes, ma'am?
Is she providing resistance against your hand, or
No,
is it just
no, it's just
raising it?
passive range of motion. And they're just going to tell me that that pain reproduces all the way down the leg. Okay? Now turn over on your stomach. So that indicates for the L4-5, L5-S1 levels. In some cases, in the higher lumbar levels, you can get disc herniation or foraminal stenosis as well. And so it's just the reverse. Because of the curvature of the lumbar spine, and nerve root impingement is going to be more apt to recreate their symptoms by pulling out. And that's the femoral nerve stretch right there. That'll recreate their symptoms. You can sit back up. So in a higher lumbar, they're going to get pain in their flank area down into their medial thigh like this. And so it will recreate, that femoral nerve stretch will recreate those symptoms as well, or exacerbate the symptoms. Okay. We're going to do it now. So I'm going to go in, and what I showed the ones earlier, related to a back exam. So two things that will cause that radicular pain is what we call foraminal stenosis or a disc herniation. And one way to kind of look at that is to have them, so if she's got radicular pain down her right leg, if I have her do lateral flexion towards that, and that makes the pain worse, then that is more likely to be what we call foraminal-stenosis, because I'm taking those vertebral bodies, wedging them together there, and that's going to close the foramen down a little more and put pressure on the nerve root itself. If I have her lean away and that increases the pain, then that's likely to be a disc herniation, because I'm pushing those vertebral bodies this way and it's pushing that disc towards that nerve root again. And that's generalized, not 100%, but that's a good way to kind of get an exam on somebody to get an idea. The other thing is if you move them away and it actually makes their pain better, that would tell you foraminal-stenosis, because you're actually opening that hole up a little bit more. Okay, so if they actually get better when you move them away from it, that's probably foraminal-stenosis as well. Okay, so that helps you kind of decide what you're dealing with. And in both cases, when you got that radicular pain, that's an indication to at least get x-rays and probably an MRI, especially if they're not getting better over a period of weeks to a month or so. Okay, go ahead and lay back again. So we're going to jump to the knee. Okay. Now, in the case of a knee effusion, so joint fluid in the knee itself, I'm going to take and kind of push down on the thigh and milk that down. And the kneecap is going to be kind of floating in there because of the joint effusion. So I'm going to push up and down. Normally, the kneecap is sitting in the trochlea and it won't bounce up and down. It's riding bone on bone there. But if you get an effusion, it's going to kind of float up and you'll be able to bounce it up and down, dribble it up and down. And that's ballottement. Bulge test is where I'll take and I'll sweep the medial aspect of the joint, and that kind of pushes that fluid to this side, and then push on this side, and you'll see that fluid swish back over and push out and bulge out on that medial side. Okay, that's a bulge test. So both of those are for joint effusion. Now, I've seen providers get confused about fluid being in a joint versus in front of the joint. The prepatellar bursa here can swell up and you can actually get an effusion on the front of the knee that's not in the knee joint. So make sure when you do an exam, you're feeling that. Is if it's a prepatellar bursa effusion, there's no fluid in that joint. And I've seen people actually stick a needle in the joint thinking they're gonna get fluid out. Okay, so you gotta pay attention to what you're looking at. Joint fluid is gonna be in the knee joint itself. A prepatellar bursal effusion is going to be swelling and puffiness and fluid on the front of the knee itself. It doesn't go into the joint itself. Okay. Okay. So slide up more on the table. So McMurray's test. This is one of the technically the hardest ones to do, to be able to perform. So with the knee, you're going to have your thumb and your finger on the joint line, okay? The way to find the joint line is to come on either side of the kneecap, or the patellar tendon, and you'll feel kind of a little triangle area. And you can follow that out till you put your finger right on that and you move that knee like that. And I can feel my finger right on that joint line, because I can feel the tibia and the femoral condyle and my fingers right in between those, okay? And the same thing on the lateral side. I'm going to put my thumb here, right where that joint line is. Now I'm going to take and hold the knee, so I'm going to have good control of the foot here. And I'm going to test the lateral compartment first, which is out here where my thumb is. So I'm going to pull her flexor, pull her into a valgus stress, and then I'm going to internally rotate to load that knee. So what I'm doing is I'm compressing that lateral joint compartment onto a meniscus. If it's torn, when I straighten this out, I'm going to get a click there. I'm going to feel under my thumb a little click, okay? And then immediately I'm going to bring her back up, put her into a varus stress. Still got my finger on the joint line there. Externally rotate. and then extend. Same thing, I'm feeling for that click. Okay, so I'm gonna go through it quickly, just relax. So I'm gonna go boom, boom. That's the McMurray's test. Okay, and that's testing for a meniscal tear. Okay? Anterior posterior drawer. Come in here and look at this. So normally, the tibial tubercle from the side, this will be better. Tibial tubercle and the patella tendon are about equal when you look at it from the side, okay? Yeah, move around this way. So what I'm gonna do, anterior posterior drawer, as you can see this is level, I'm pushing down, and that stresses the PCL, and up, and that stresses the ACL. And I'm just looking for translation of this tibia to be moving back and forth, and hers is very stable there, okay? So that's an anterior drawer. You can also sit on the foot to stabilize things and do that. Then I'm gonna move down. This is a more sensitive test called a Lockman's. So I'm gonna hold her thigh and stabilize it. And this hand's gonna be on the tibia. And again, I'm pulling forward on the tibia and stabilizing that thigh, feeling for that translation of that tibia to come forward. And that's when an ACL is torn. If it feels loose, check the other side. If there's no injury there, this one is tighter than this one, and they've had the injury, that would tell you about more than 1 centimeter of translation coming forward of that tibia would tell you ACL is insufficient. Okay? Now, varus and valgus stress to test the medial and lateral collateral ligaments. So the MCL's right here. Don't do this with a fully extended leg because actually the bones lock it into place. So you want to go about 20 degrees. Put my hand right at the knee and my arm down here. I'm just stressing that MCL right there. I can feel that bounce, but there's a good end point to it. Okay, same thing over here. As I'm going to get her 20 degrees flexion, stabilize the knee, and I can feel that lateral collateral ligament there. It's just got a good end point to it. So if they've torn that, you again can compare it to the contralateral side and feel about how much laxity it is. If they have an acute injury to it, it's going to be very painful to do that test, and they won't tolerate that very well. But you want to try to get a good feel to see if there's an end point or not. If it's completely torn, it's going to open wide open. Okay. Thomas test. We're looking here for a hip flexion contracture. So this leg should remain on the table when I flex her up and do this. And so you notice that her leg stays down there nicely. If that leg comes up like this, that tells her she's got a hip flexion contracture on that side. Go ahead and stand up. And last test, Schindlerberg. And what we're testing for is hip abductors. So I'm going to have you raise this leg off the ground, and you're watching for that pelvis to drop down on that side. If it does, then the weight-bearing side has weak abductors, hip abductors. And then switch sides, raise that up, and you notice that her pelvis does not drop down and tilt like that. So she's got good hip abductors. Okay, that completes your exam.